in the interest of saving a little bit of time, Dr. Mowat said I can just simply introduce him as Dr. David Mowat.
Okay, can you all hear me okay?
Yes.
Okay, good. Just stick your hand up if I start mumbling, and I'll try and speak more loudly. So I've got this rather long-winded title. I don't know whether, did I think of that or did you?
You did.
Did I? Well, that's good. Right, well, that's what I'm going to talk about. I mean, it's important to realise a lot of what you've just heard, what I'm talking about is, it's kind of got a real medical focus to it, because, you know, we're doctors, and it doesn't really tell us the day-to-day story that you guys know a lot better than I do about really what your lives are all about and how beautiful your children are, and young adults, but how many problems that they have and how that affects you guys. I mean, we have, coming to a room like this and meeting you guys, it really has a big impact on us about the reality of what you guys go through. And, you know, I think we've got a lot to learn from you, actually. And I think there's more knowledge in this room about this condition than there is in any paper. And I suppose the most important thing is that each of you have to be the advocates for your child, as you already know. And you talk to doctors who are meant to know things, and you realise that actually you know more than they do. And I think what you have to do is, rather than necessarily search for the doctor who does know everything, you have to work with the doctors that you have access with, and encourage them to talk to others, and that's what we do. We do talk to each other, and no geneticist is an expert on Mowat-Wilson syndrome, because even for us, we've only seen you know, maybe 20 individuals in a clinical sense. And whilst we run a clinic occasionally, we've run 2 over the years, and that's been very successful. There are only 6 in each of those clinics. You know, that's just really touching the sides of really what's going on. So we're very conscious that we're not able to provide everything that really families need. Anyway, so after that rather long-winded introduction, which I should have had these pictures up when I was doing that. So these pictures really tell the story, and you've got all lovely pictures that I've seen already of your families, and this is the day-to-day pictures rather than the clinical pictures that you see in medical journals, which aren't always nice. All our kids and families, they do stuff, and that's what it's all about. You've already seen Sydney. Drop in if you're ever coming by. Yes. Occasionally I get a call, and I'm just getting into Sydney for a couple of days, can I come and visit? If we can fit you in, we will. Just come up to the office and we'll have a chat. That's no problem. We're close to the beach if you want to swim to that as well. So today, I was just going to talk a little bit about general management recommendations once the diagnosis is made. It's really important that you have a good clinician. You've got to have one doctor-go-to person who is going to go and help you navigate the system, and that could be a good general practitioner or a pediatrician, depending on what your health system is. The generalist is a really key person here. They don't know all the answers, but they may be able to help you find who's the right person. And the team approach is really important. And if you get too focused on one subspecialist, then you deal with that, but you don't deal with the other things. So you need a good generalist. That would be my strong advice. I'm going to focus a little bit on Hirschsprung's disease seizures, not so much on communication, a bit on behaviour, just from the knowledge we have, but we really have lots to learn. And I think you guys are on a journey, and hopefully as time goes on, a lot of the things you're struggling with early on will improve, and just like parenthood, you'll be struggling with something else in your children as they get older, there's a lot more that you need to think about than your average child. There's huge gaps in our knowledge, and I think one of the things about this meeting is that it can bring together this the collective spirit, where we might actually think about how can we as a group, that means you, not we as me and Meredith and Margaret, that we can help, that we can actually make something from this that goes forward to actually provide more information. So new families coming on board who are diagnosed, their child is diagnosed at a young age, or an older, a young person diagnosed in adulthood, there is better information, and you guys can go armed with this information to your various doctors and say, well, don't worry about it, it's rare, this is the information, and now do your job. And I think, that's, if you do that politely, people really respect that, rather than assuming that the knowledge is already there, because it's not. So there's several management articles that touch on management, and this is the first one that we were able to review in 2003, which I find a little bit in there. We've got links to this on some of your websites, and I think that's one of the things the website does. There's, what is there out there in the literature should be linked if possible. And then there's Margaret's article that Meredith has already talked about, which really kind of focused on management, and that's what we need to build on. Margaret also has written what's called the Gene Reviews, and that's readily available. And again, I think there might be a link on the website for that. It's a really, really helpful document that covers things very succinctly but comprehensively. And then Meredith and I also were asked to contribute a chapter in this book. And again, I don't know whether you've actually got that, and I think we ought to ask Susan Cassidy and Judith Allison whether we can actually have access to that, so that that's put on. Because again, that's more of the same, but it's a little bit more in-depth, practical help. It doesn't by all means cover everything, but it is useful information. So all families should have this. Not everyone is going to be experiencing the same things. Some families, the child may have Hirschman's, some not. So you're all sort of experiencing things a bit differently. In our clinic, and the way we kind of adopted this on a couple of occasions now, we'd like to do more. I mean, I'd like to do a clinic maybe a couple of times a year. There's about 20 or 30, probably about 30 patients in Australia and New Zealand that we know of, and we'd like to sort of get the folks in and just go through everything on the same day, make it a little bit more user-friendly. Geneticists have a good general view, but we need help from our subspecialists. So what this clinic is, it's all about persuading your friends and colleagues to come along and help out. So I have a very friendly neurologist who helps advise on the seizures, and a number of our pediatric surgeons look after the Hirschman side of things. Liz Evans, some of you have met. She came and did a PhD on behavioural sort of aspects of this condition, and she visited the US amongst other countries as well. And the key person in the clinic, I think, for the future will be the speech therapists or the individuals who's going to advocate in terms of the communication. And we're in the right era to actually maximize communication with iPads, etc. Expensive devices, but I think actually are going to open up the world for individuals with this condition, whereas before the communication, understanding and receptive language, really surprisingly good, but communication is really seems to be a major block, and I think that's the area that we need to concentrate on, and we often do involve our sleep colleagues as well. So this is where the medical bit comes in, and again it's just things that are a bit overwhelming, but these are the sorts of things that we recommend at the outset that you make a diagnosis. If you haven't already done these things, then this is what we recommend that should happen, because you may not pick up a structural heart anomaly just by listening to the heart, so they all need an echocardiogram. You need a good dental examination. All our children need dental examinations, but children with this condition, it's a much more practical problem, but it is important because pain threshold is very high, and so a lot of children won't tell you that they've got discomfort and you could have dental abscesses happening and you don't even know about it, and they can be a trigger for seizures. So this little thing like preventative care like that can actually help enormously. Talk about eye examination, hearing. If you're going to maximize communication and understanding, there can't be some other intercurrent problem with hearing, mid-disease, etc. like that. Constipation is very important to be investigated. Not all children will have Hirschsprung's disease that is actually amenable to treatment or surgery. Constipation is very common in intellectual disability children anyway, and so trying to get the right management to match the child is really important. Obviously managing the seizures, renal anomalies, etc. The neurologist, I think, has a key role because seizures are so common, and I'm going to talk a lot more about that in a minute. And obviously the development and educational needs of these children to maximise their day-to-day enjoyment and functioning. And eye examination, cardiovascular, talk about GMA. So there's a lot of people that potentially need to be involved, which is why I think it's helpful to try and at least once a year or once every couple of 2 or 3 years try and get to a multidisciplinary clinic if you can. And I think that's a model of care within children's hospitals that we should be adopting. So this is what we would kind of recommend for you guys. Liz Evans found strabismus as squint was a lot more common than we originally noticed, and I think the eye examination frequently, just checking actually what vision is like, is very important. And I think monitoring for ear infection as well. And then it's the development, I think, in looking at those communication needs, which where you need to put all your endeavours into. The medical problems that come over the top with bowel problems and seizures, but you need to get back to communication all the time, and I think that'll pay off in the long term. So just some comments now about Hirschsprung's, and obviously that's a major feature for some of you, some of your children. Constipation needs investigation and a very low threshold for thinking about surgery or having the correct biopsies. I find it extraordinary that anyone could be diagnosed with this condition and hasn't seriously seen a pediatric surgeon with a view for a biopsy if they've got constipation. Just because constipation is common in children with intellectual disability doesn't mean you just don't bother investigating. And I was telling some others about a young man who had very challenging behaviour, and at the age of 28 he was diagnosed as having short segment brains. A lot of his challenging behaviour improved once he finally had his surgery and ended up with an ileostomy at the age of 28. So that should be happening. Other gut motility problems are there, so it's not just confined to the lower part of the bowel. There can be other functional gut problems, and we need to understand more about that, and more research is needed. There is very little research or information on Hirschsprung's in Mowat-Wilson syndrome. There's a few case reports, and various things are said like it's always terrible, you need lots of TPN, there's awful infections afterwards. We need to sort of really have a good understanding of what is the cross-section sort of symptoms across our children to really be able to judge, well, is this just normal and what can we expect and how will things happen over time? Or is this out of the ordinary and we need to investigate this further? If we don't have that baseline information, you can't really make those judgments too well. So I think that's an area of research that needs to take place, and I'll tell you a little bit about that. And in series of Hirschsprung cases, there often are 1 or 2 cases with Mowat-Wilson in there, but that's not enough to really tell the story. So we need more information. More data is needed, key data is needed. And these are just some of the things that people talk about that we need to know about. So with a German group who are into elimination, which basically is bowel and bladder function, and I don't know whether any of you sort of seen this in any of your trawling of the web, but in Homburg in Germany, Alexander von Gerard and Justine here, they're putting together just a survey, which is just questionnaire based, to really answer some of the question about day-to-day function of incontinence and what sort of procedures happen with a focus on the bowel and bladder. And this is just some information that they gave me about their study, which I've really covered already. This is what we kind of we know about incontinence what do we know about incontinence in Mowat-Wilson syndrome? We know that in children, about 30 to 40% of children, a 7-year-old child with severe intellectual disability will have lots of daytime and nighttime wetting and soiling. And so, for this level of developmental delay, we know that these problems become part of the course. So, how different are things? Well, we need to know what the information is for our group here. So they're looking at a questionnaire. It's fairly simple, it only takes 20 minutes. There's two components to it, looking at bowel and bladder function. And there's also a developmental behaviour checklist, which is a sort of a developmental screen as well, which many of you have already had done. We've done a little bit of preliminary study just on 6 families, 4 boys, 2 girls, and these are the sort of results. I think this will kind of fit in with a lot of you guys will know about these sorts of figures anyway, about nighttime wetting, daytime wetting, and a lot of 4 to 6 bowel problems with fecal incontinence as well. And then at the same time, there's information that's coming that you layer on top of this is there other associated anomalies which are clearly a factor. So every child is different, and so therefore you need more information to sort of look at the variables and how do these things interact with each other. So I think these slides are probably available as well afterwards, but this is the email for the researcher who's doing this study, and all you do is email her and she'll send you the consent form, and you fill in the questionnaires. And I reckon if they could get 100 cases, 100 questionnaires, that would be pretty extraordinary. So, if 30 or 40 of you from this meeting, that will be a huge boost. And then this information then gets out there. There's actually an elimination conference in Australia, and they're presenting this data there. So this is what we have to tap into, is people who actually want to do the research, and then you can then feed that information back to your clinicians locally. We can't all do the research. We have to pick the people who are going to do it. Just have a little bit of a break while I just grab some water. So we talked a little bit about seizures, and again, there's a lot of information on seizures in various studies, but no one's really done a good systematic review, so that's really important. What we do know is there's no particular seizure type that is characteristic of the disorder. The age of onset can vary. Often seizures will happen early on in most, that seizures are a problem in adulthood as we go by, but that's we think things tend to sort of subside, but we haven't really got good data on that. There's a whole lot of different seizure types, and I think you guys will know that a lot better. And if you're just talking to each other, you'll share experience about how these things can manifest, I'd be surprised if we don't see seizures over the weekend, over this particular weekend. We may have done already, and in the last Mowat-Wilson day that we had a couple of years ago, that was quite an upsetting thing for some of the families, because when you have a room full of people with Mowat-Wilson, somebody's going to probably have a seizure, and it is upsetting. So that's why it's challenging coming to these meetings. some of you may be completely more used to that than others, so it can be quite a difficult thing. So this paper by the Italian group looked at 22 patients. It was selected mainly because they'd all had at least one seizure, so it's very helpful data, but it has got its biases, and it just gives you the age range there and the types, and they looked at the therapy, and they also looked at the use of serial EEGs, and they were advocating EEGs being used a little bit more to try and sort of get a judge, well, what's happening, when you think things are actually not too bad, what is actually happening with the EEG? And there's a big debate amongst neurologists how helpful an EEG is at that stage, but they were advocating maybe we ought to be looking at the EEGs a little bit more, because a lot of people can be having sort of more minor seizures or absent seizures and you don't even know that it's happening, and just being aware of that, maybe you can tailor the medication a little bit, get people a little bit more online. So they had a mean onset of seizures around 14 months, and that would be our experience as well. Usually the seizure was focal, in other words affecting one part of the body first, and then it might evolve into something more generalized, and often the trigger was fever. Now you can't stop children getting infections, they will get infections, but it is important to treat infections as best you can with the usual kind of measures, and anything that such as any endophthalmitis or anything like that may need specific treatment to avoid that trigger. The other thing that they noticed quite a lot was these what we call atypical absent seizures, and these are seizures that happened a little bit later, and they're sort of brief episodes of unconsciousnness, and there may be an associated behaviour with it, so something's a little bit sort of strange. That's kind of why that's happening, and is it just like a mannerism? But I mean, often it will actually be a seizure rather than a voluntary thing. So that's important, where the neurologist may use something like that to judge the medication. So just being tuned into that is very important. I think iPhones or the ability to take video is really important, and you flick it off to your neurologist. That's actually worth more than going to the neurologist, actually. It's taken a lot of time, and then you can get some advice about maybe tweaking the medication perhaps. So those are things that I think you should be thinking about. There's no one anticonvulsant that seems to kind of work. The neurologists know this better than I do. When we do MRIs, it doesn't correlate with what we see on the MRI, whether the seizures can be bad or not. The agenesis of the corpus is not predictive. In fact, other major structural problems of the brain are not very, very common. In fact, we're still trying to understand why a seizure is so prevalent and so common in this condition. And I think there's some evidence. I mean, this gene is such a key gene early on. It's responsible for altering so many different parts of the body, how it's developing. And we're only just starting to understand that. But it looks as though the gene does have an effect on some of the neurons, in this particular neurotransmitter called GABA, and this is an inhibitory neurotransmitter. So basically we have little chemicals in our brain which need to be about right. If they're a bit out of whack for whatever reason, then seizures are much more common. And when we can understand that a little bit more, we may be able to actually unlock treatment a bit better. And there's some interesting work along those lines. And this is kind of just a little paper that has speculation about this and some study on a mouse model. And if you're just showing this is sort of the evidence of the brain, and this is the nerve cells which start off here near the ventricle, and they kind of migrate around to the surface of the brain. And this is the normal situation where you get a combination of different types of neurons occurring here called interneurones, and then the ones that form the cortex migrate up here. And so if that process doesn't work so well, you're set up for seizures. If you like, you might have an excess of these neurons here, and they may be a focus for seizure, which you can't see on the scan, but that's what's happening in the connections in the brain there. And CYP1, the gene product of Z2, is a very important component of these cells being able to do what they need to do and get where they need to get. And sort of understanding this information may even lead to sort of some novel approaches in terms of some treatment. So I think with intellectual disability, I used to think that everything was hardwired. There's nothing you can do, it's just the way it is. But I think there are some conditions teaching us that you can have targeted therapies the more we understand things. And I think any benefit, small benefit for an individual with this condition will have a huge impact on day-to-day life. So I think there's always hope that more knowledge will lead to better outcomes. Our own survey in epilepsy sort of mirrors a little bit what was happened already. It was only on 13 patients put through this. And this was the age range, so it's a slightly older group, and 11 out of the 12 had seizures. 10 of the 12 had had seizures before the age of 4, and none less than 3 months, so often will come later. It was most severe when childhood. 6 of our patients had had episodes of prolonged seizure, or status epilepticus. Many of you would know about that. There's different definitions of what that is, but it's pretty scary, and they keep going, and that's is a worrying problem that people have to deal with. And then just to the range of different types of seizures, again, no type, but absences again were common. So lots of patients had different seizure types. However, 5 of our 11 who were older were no longer taking anticonvulsants. So some of you may not even imagine a life without anticonvulsants, but that may well happen. And again, in the room, when you look at your older people with the condition here, you may well, whilst that's scary when you've got your young child to even think about that, there may be aspects of the things you're dealing with now day to day with the bowels or the seizures where actually they maybe do settle a little bit and become a little bit more manageable. And 7 of our patients that we looked at, which was unselected, were seizure free, which was quite encouraging. So I think clinicians need to be aware about a broad range of epilepsies. All neurologists should be able to manage this and talk to colleagues if they've got problems. But we need to do a lot more in terms of what medication works for what type of seizure in this particular condition. And at the moment, when you're trying to kind of use a broad range of medications, you may be missing actually the one that seems to be working, and that's all about numbers. If you're not getting enough numbers, you can't get the trend, and so you may be bypassing something that actually does help. It's just getting lost. So I think more data is really important. And using sleep and awake serial EEGs may be helpful, just to give you an idea of what the background is. This is a little inner harbour beach called Nielsen's Park, which I asked Meredith, did she recognise it? And she said she didn't, and I told her where it was, and she said, oh, that's where I got married. Sorry. I'm not sure whether I'll tell Bruce that one. So that's really good. And you guys will see the shark net there as well. So. But it's no problem, the sharks aren't a problem. And now I've completely run out of time. Have I run out of time? Okay. Oh, good, because I haven't even started. So this is really kind of work by Liz Evans, and it's kind of the unstructured part of her work is probably the most interesting, because it's what she learned really is when she just went to families' houses, met with the family, met their children. The actual data she collected in the sort of standardized form was the least useful in a way, because the tools that we use to measure things are not very good, particularly for this condition. And what's really depressing when you read the data on this. People talk about severe, profound intellectual disability. Well, you only have to kind of be here at this meeting. We know there's an intellectual disability, but we know functionally a lot of our children, these children, just do so much better and are so in tune with what's going on. And so it's very depressing when you read a lot of the data, and it doesn't really tell the true story. And that's why I think it's so important to work hard to actually achieve more. And one has to really educate others that when they do read, the pediatrician might read about this and read the level of delay and not really fully understand that actually there's something to work on here. That's a really key message. So these are the sort of kind of case reports we had, usually much more of the severe to profound, much worse receptive language problem, better receptive language problem, than speech, development markers of milestones, and this kind of nice, classic, affectionate, happy nature, and I kind of think it must be actually all the parents of children with Mowat-Wilson are great parents because they've got children who are like this, and I think it's a reflection of you guys, almost completely. So this is the paper, and again that should be linked to. And I think again it's medical, but it's worth a read. And I think that it's very nicely summarised things as well. And I think those are on the website with links as well. I'm looking at Debbie here, and it's sort of it makes a little bit more sense and isn't such a sort of a sterile read. And I would recommend reading those things when you're feeling strong. You might say, why do people research behaviour? And I think that we can unlock a few things about this condition. It might teach us a little bit more about some of the sort of the basis of being happy, generally being accepted, go with the flow, and so whilst I'm pleased that when we research this condition, whilst there's major problems and challenging behaviours and all those difficulties, there is this light as well. And we're not talking about so much major mental health problems in terms of depression or other mental health issues. We're actually talking about, well, actually, if you can get someone seizure under control, who's comfortable, not in pain, actually functioning is really very good. So understanding the pathways involved in that and how they change in this disorder can open up avenues that might actually help the wider population. And the idea is so we can do something as time goes on, and a better understanding of behaviour obviously kind of helps everybody because there's nothing, uncertainty just sort of kind of leads to people jumping to the wrong conclusions, doing the wrong thing. So I think information is so much better. So the aims of this study was to kind of look at the behavioural phenotype, which is sort of the technical way of sort of saying the day-to-day function. How do people develop? What do they do for themselves? What are their strengths? What are their weaknesses? And more importantly, compare those with other groups. So there was a sort of control group, so we matched for IQ, but also other particular conditions to see how they differ. Other genetic conditions like Down syndrome and Williams syndrome. And the same approach had been taken. So this was the age range, so someone as old as 51 was part of the study. Across Europe and Australia and Japan. A lot of we translated all the questionnaires into lots of different languages, so we didn't limit ourselves to English speaking. There are 122 controls. These are the range of sort of measures that we used, and I won't go into them in any great detail, but the bulk of it was 71, so we went through this sort of questionnaire. There were some care interviews looking at quality of life, etc., and a small one looking at sleep. And I can only summarise really rather than the detail, but this is where things really came out bad, and I think that's because the tools don't really reflect what's actually happening. Receptive language was better, but not as much as we think day to day. The measures weren't showing that as clearly. There's definitely a strength in social skills, but weaknesses in daily living skills. And you dissect that down to someone who's that, I can't go into that. And there was learning as time went by. When you looked across the age ranges, there was no suggestion that things just stagnate and stop. There's always learning. We're all learning all the time. You know, we're all surprised by what our children can do, and celebrate every new thing that comes along. So on the checklist, which was the measure, there was sort of statistical difference in terms of sociability, lots of oral behaviour, lots of stereotype behaviours, which you know, and an underreaction to pain. The overall level of behaviour problems, whilst we get the impression maybe they're a little bit less than some disorders that in some individuals we see similar levels of cognition, but actually that didn't measure out. Baseline of about 30%, something like that. A little bit on language. And this is the bad stuff, that most people are non-verbal, but more and more, and Margaret's probably going to talk about this, this is not the case as, you know, more cases are coming out where actually much better language skills, and actually if we're going in a little bit harder earlier, then language skills actually may well improve, and using augmented communication aids actually helping enormously. Some people have no words, some small numbers, some lots. Average onset of speech quite delayed. Other means of communication, non-verbal methods, and interpreting what's happening. I mean, you guys are better, you can interpret things way better than I could. I'm sure if I go up to the room soon, you know, I'll kind of be completely overwhelmed, and you guys will be going, oh no, that's just, I will do that all the time. Yeah, but, so in fact we might do that, so test it out. A little bit on sleep. Now, this is actually kind of putting this together as well, and I mean sleep is such an important thing, and because it impacts on us, and you know, the parents as well. So it's a really important part that needs to be kind of managed as well as possible. The good news is that while sleep is a major problem, it's no more major than any other condition in a way. But it does need approaching, and I think sometimes you do need kind of help in what are the strategies there. When you look at the data, there's lots of early waking, lots of nighttime waking. And you know, falls into a range which, you know, clearly will go on to lead to other problems that spill over during the day. If you're not getting a good night's sleep, it's very hard to function. You feel a bit like I feel now. So these are just sort of some of the unstructured sort of comments. A lot of chewing, a lot of mouthing objects, and so a lot of sort of having something that individuals can grab, which is attached to them. They can grab and use that because of the oral stimulation, which is safe, because a number of individuals just kind of pour things into their mouths and just chew it, and it can be horrible, a real safety issue. And so I think it's very important that there is that opportunity to do that. You can't necessarily stop that. At different times, all kids will do this, but you know, these phases last a lot longer, and you have to train your children on what you can and what you can't eat or put in your mouth, and clearly that's a longer term project. A lot of flicking, tapping, twirling, a lot of teeth grinding. I don't know why that is. I mean, I don't know, because is that a visual thing, or is that just a get close? And the other direction. unrealistically happy or elated. Isn't that right? And these are less, these are less often in Mowat-Wilson driven than control group. So they're less depressed, less downcast, less unhappy. These are good. Didn't cry as much for no reason. Did show affection. Less change in mood. Or usually had a reason. One thing I've noticed, and I'm really interested in you guys, I think people with Mowat-Wilson, they're real good observers and knowing what's going on and want to be involved. Aren't so good at initiating, happy to do something, but I'd like to be an observer. That's what I think. Happy to sit and watch and things go on around. Whereas, you know, this drive and some children with intellectual disability have this amazing hyperactivity and drive. But these are just my impressions, I don't know. And don't complain as much. So a lot of those things are good. And then small page for lovely Drawing, I mean, I'm sure you're teaching, you know, your children drawing is an issue and socially it's important and you can teach, you know, the drawing needs to be managed and program about that. Whether the squint, that seems quite common, whether that's interfering with fine movement, because Liz felt that fine movement was a problem. And I don't think we've really worked out exactly why that is, whether it's a brain problem or a visual problem or what. Defensive. And then these are sorts of things I talked about. Obviously get the vision looked at if you're worried about that. If there's a change in behaviour, well, why is that? What's happening? You have to be a little bit more clear. Screen for things, sleep disorders, etc. Get some safe sort of chewy toy, etc. Teach to swallow, and augmented communication always, because if you can't get your message across, then you know it's very frustrating. So we need research on interventions for communication and mobility. There are milder forms of MWS which are coming out, which just are not being recognised. They don't actually have any structural anomalies. It's really just a facial feature and some mild intellectual disability or moderate intellectual disability. And there's a lot more out there than you know, and you guys may even kind of pick them if you see children. You may know the diagnosis before the parents do. More understanding about the GI problems. We need more understanding about the epilepsy and the role of neuroimaging and other forms of imaging, and the role of the gene in neuroimaging. The only way we do this is we get a group like this and we put that to good use and we do something from this point onwards. And I think that's the aim of the board, and we are keen to help with that. And you know, we can mobilise, I think, a whole lot of families right across the world to get this information. So I think that's really exciting. Actually, a very important day today. So these are some of the resources again, which are links that are on the website as well. This is the Hirschsprungs, which may not be on the so much, it may be. There are some families just gave me these ones saying that these are really good for Hirschsprungs. Lots of goes through all the procedures and different options, so you can actually get your brain around the complexity here, because it's really complex. And if you don't sort of understand that and speak the language, when you go to the surgeon, you know, you're really at a disadvantage to advocate. So you really sort of do need to read about these things, I think. And these are some of the Mowat-Wilson ones, and we'd like to thank Rod, who made this. I don't know why he chose this name for it, so it's slightly strange. It's not nearly as quite right, but anyway, he made a fantastic movie that's going solo. We've all sort of hopefully have seen. And as you can see, he's a very stylistic man, and his photographs are beautiful. So I'd just like to end on just some more pictures of some of our Australian families. Thank you very much indeed.